So, good afternoon, everyone. My name is Sarah Dugan, and I came across this article a little bit ago as we were building out the curriculum, and I thought it might be of interest specifically to this group. So, we're just going to focus primarily on this particular journal article, looking at allergic diseases and mental health. So we will talk a little bit about the proposed mechanisms, but the focus really is going to be the prevalence. So seeing what the overlap is between some of the allergic conditions as well as the mental health conditions. We'll talk a little bit about some of the treatments, what might be beneficial, what might not necessarily be quite so helpful for these particular patients. So this was the citation. Excuse me, the article itself is posted for you on the iEcho platform, and these slides are also posted on that platform. So let's start with a little bit of background. So why did the authors want to look at this? They talked about how there has been an identification of the overlap between patients who have allergic conditions and those that have mental health conditions. Some of the first reports were more than a century ago. I was able to come across an article that was published in 1963, so not quite a century ago, but that really went into a little bit more detail talking about this relationship. So the original description was allergic toxemia. So the authors in the paper focused on patients that had an allergic condition and were manifesting with additional symptoms: slowed thought process, poor memory, mood disturbances. When I looked into the article that was published in 1963, it went into even more detail. So it talked a lot about how these patients often would lose their appetite. So they didn't enjoy food anymore. Their overall nutritional intake was significantly less. They began to lose weight or were unable to maintain weight. They talked about having significant fatigue. The age range for the patients went from pediatric patients through geriatric patients. And one of the items that was noted was for some of the pediatric or adolescent patients, they were identifying that it seemed like their parents, caregivers, teachers had much more energy than what they had. So while they were kind of okay with their peers having more energy, when it hit the threshold that they were really wiped out and fatigued significantly sooner than what they saw parents, caregivers, teachers being, that was when they would raise it to the concern of a healthcare professional. They talked about what sounded a lot like anxiety or depression. There were a number of sleep difficulties. And one thing that I thought was interesting was they weren't interested. They felt like they were living half a life, that they really lost pleasure and enjoyment in most of the activities of daily living. And this seemed to coincide with their allergic conditions. And it wasn't necessarily clear to the authors. And I think what we'll see is we still don't have a very clear understanding of whether or not this is mental health driving the allergic condition contributing, or if there's another relationship between the two. So identified for an extended period of time. And there are a lot of individuals, there's a lot of interest in trying to understand what that link is between the two. So between the allergic disease and mental health conditions, one of the more prominent theories that's out there that we'll talk about, I think, with almost all of them, is inflammation. So related to an inflammatory condition that creates the allergic condition, that inflammation not being localized, so really becoming much more systemic, resulting in neurotransmitter disturbances, which may then contribute to some of the mental health conditions that we see. On the flip side, the other thing that has been talked about is possibly that the overall weight and significance of having a chronic condition may result in social implications. So for patients that may have atopic dermatitis, for example, that was one of the categories that the authors looked at. They may feel more uncomfortable, especially in the summertime, being out, especially if their affected areas are uncovered. So maybe they're not being quite as social. They're not able to go to the lake. They're not able to go to the beach, to the park. They don't want to be outside in the sun if that's a trigger for them. So it may reduce their ability to be social, to engage in activities that they enjoyed. They may be much more confined. So allergic rhinitis is one of the other areas that we'll talk about. So what are the triggers? What are the triggers that cause allergies? If it's going to be something like animal dander, then maybe it doesn't matter and it doesn't impact their ability to go outside. If they're anything like my husband and my daughter, spring and fall are pretty rough for them in terms of allergies. And as it's raining all of the pollen and you see yellow everywhere, including coating your car, they cannot be outside. It's really difficult for him to be out, my husband to be outside specifically. He ends up sneezing like crazy. His eyes will water. He barely can breathe. So if those symptoms are going to be that much more significant, then maybe it does reduce what their overall environments are and what they're able to engage in, which might then contribute to some of those mental health symptoms. So I feel much more socially isolated. I'm not able to do things that I want to do. We know that there's a relationship between being outside and mental well-being or sense of well-being. So if we're not able to be out in nature, then potentially that also gets reduced. There likely are a number of other factors. So is it genetic? Is it greater environmental? Are there other social determinants of health categories that may be involved? So it does appear that there are multiple possibilities for why these two types of conditions are linked. So how much are they linked? We're going to look at a list of allergic conditions that the authors focused on. This is obviously not an all-inclusive list. It was just the list that they had included here. We're going to focus primarily on prevalence. So what did they find in terms of how often do mental health conditions pop up with these different allergic conditions? And then why might that be happening? For a couple of them, we will talk about some pharmacologic treatments. So are they helpful? Are they harmful in terms of the mental health conditions when we're trying to treat the allergic conditions? But that will just be for a few of them. That, as a pharmacist, I would have liked to see more of that, but that's not what was included in the article. So that's not what we're going to go through today. All right, so let's start with allergic rhinitis. So one of the most common allergic conditions, interestingly, up to a third of patients who have been diagnosed with allergic rhinitis have been reported to have a reduced quality of life. So that reduced quality of life may be due to significant symptoms. So they're just in distress or feeling uncomfortable as a result of symptoms. The symptoms may result in difficulty with things like school or work performance. There was a small survey that was done of individuals who were seen at a primary care clinic diagnosed with allergic rhinitis, and they asked them about their work productivity. And about a third of them did acknowledge that they felt that their work productivity was impaired, specifically as a result of their symptoms. There are two categories of symptoms of allergic rhinitis that have been associated with sleep disturbances. So conjunctival involvement as well as laryngeal involvement. My daughter is homesick. She's been homesick for a couple days. She definitely has things going on with her throat. Started out just being a smidge red and is incredibly swollen to the point that she has difficulty swallowing, but she also has difficulty talking. So she couldn't even call us in the middle of the night when she was having trouble. So this was something that woke her up, that really kept her fairly miserable and in bed for the last 2 days. So with the involvement of those type of symptoms, it's been significantly recognized that sleep is impacted directly. That has been shown to decrease overall well-being It's been shown to decrease concentration, short-term memory, school performance, but it also has an impact on susceptibility to other illnesses as well as leisure time. So more of the individual's day, especially if they're highly symptomatic, tends to be taken up just in dealing with the symptoms of allergic rhinitis that they have. So recognizing that seems to be a fairly significant trigger. How often are we seeing patients who have actual mental health diagnosis that have allergic rhinitis? So the first set of information that was included was from the National Comorbidity Study survey, the replication survey, and then the National Latino and Asian American survey. So that was a survey that was developed very similar to the National Comorbidity Study, but that was in several other languages, specifically to try to identify 12-month prevalence of mental health conditions for these two ethnicities. What they found was in individuals who self-reported that they had seasonal allergies, the odds ratio of them having a mood disorder was 1.28. So they were almost, so that 30% threshold of seeing impairment, that seems to be relatively close. There was another survey. So this was a web-based survey. You'll see that there's a lot of information from Korea that was included in this particular article. So this was a Korea Youth Risk Behavior Survey. So it was provided to a number of adolescents, and they looked at, again, those that reported that they had symptoms of allergic rhinitis, including seasonal allergies. For those individuals, they saw a statistically significant increase in the odds ratio for depression, so smaller than just mood disorders in general, in the odds ratio of 1.1. But they also saw a statistically significant increase in suicidality. So suicide thoughts, any type of ideation, as well as suicide attempts. This was interesting because it had a relatively compact confidence interval. So despite the fact that it was increased just a little bit, it was of concern because it was statistically significant. So it seemed that these individuals are much more uncomfortable and may have a significant more mental health burden than those who don't have allergic rhinitis. Now, why might this be? Why might we see this in the allergic rhinitis population? Well, we mentioned the decreased engagement. So there has been a correlation with severity of symptoms and time spent outdoors. So we see a decrease in social activities as well as time outside if a patient's symptoms are higher, which seems to make sense, right? If I'm feeling not so great, I'm probably not going to want to be out and about. Pro-inflammatory cytokines. So recognizing that there are a number of inflammatory cytokines that are involved, they're also relatively close proximity to the brain. There are some theories that suggest that these cytokines can cross the blood-brain barrier and not require active transportation. So we can see an influx of these inflammatory cytokines. The higher presences of these inflammatory cytokines have been shown to interrupt neurotransmitter metabolism. So it may disrupt the production of certain neurotransmitters, serotonin, dopamine, norepinephrine being some of the more prominent ones. It may also impact the sensitivity of some of those neurons, so how significant the signals that those neurotransmitters are sending. There was so related to this, so could the cytokines actually play a role? Possibly. There was a meta-analysis that was done that included 24 studies. It included adults that were diagnosed with major depressive disorder. They found that in these adults who had symptomatic depression, their levels of tumor necrosis factor alpha, so TNF alpha and interleukin 6, both which are thought to be pro-inflammatory cytokines, were significantly higher than what they saw in patients who did not have active symptomatic depression. So we see higher concentrations of those in patients with depression, which suggests that maybe that could be a contributing factor. To be fair, that's not causation. So is it the depression that results in those higher concentrations? Maybe. Is it those higher concentrations of the cytokines that result in depression? Again, maybe. We're not able to specifically identify which direction that relationship goes in. Other potential contributors are sleep disturbances. So again, we talked about some of those symptoms that may disrupt sleep, which may result in issues related to concentration, as well as some of the mood symptoms and that social isolation. So this was one of the areas that they did talk about treatment. So recognizing that for some patients, they may be using intranasal corticosteroids. Interestingly, there was a small pilot study that was done that looked at the use of intranasal corticosteroids in patients with allergic rhinitis, and they saw decreased rates of suicidality, so suicidal ideation as well as suicide attempts. So potentially getting some of those symptoms under control may be beneficial, especially if the patient does have suicidal ideation. Now that's interesting and different compared to what we see with oral steroid use. So with oral systemic steroid use, sometimes you see greater amounts of mood disturbances. That's not necessarily what they've seen, at least in these very, very small cohorts of patients with allergic rhinitis. The other more first-line treatment that we may see with allergic rhinitis are the use of antihistamines, both first and second generation. Now, there are conflicting reports. So there are some reports that there are patients who have an exacerbation of symptoms. So they may have some increased anxiety, they may have irritability or agitation when they're using antihistamines. In other cases, we can see an improvement. So hydroxyzine often may be used short-term for the treatment of anxiety. Is it because the antihistamine is helping with some of those symptoms of mood disorder? If it's related to sleep, are they sedating so it makes their sleep better, so overall those symptoms get better? Or is there something else? So histamine is related to a number of different functions, the sleep-wake cycle. It's involved with the metabolism and expression of serotonin, so it may potentially impact things like anxiety and depression. So it's really unclear if this is due to an adverse effect that's beneficial or a direct action by some of those antihistamines. And again, unfortunately, we're not able to predict if it will be beneficial or detrimental to those patients. So it'll be something we need to continue to monitor. So allergic rhinitis was one of the larger ones, probably because it was so prominent. Most of the rest are a little bit more succinct. So atopic dermatitis was the next topic that they looked at. When they looked at the prevalence of mental health conditions, the National Survey of Children's Health looked at patients who had atopic dermatitis and found that those patients were more likely to be diagnosed with attention deficit hyperactivity disorder, autism spectrum disorder, as well as depression. So the autism spectrum disorder, I just wanted to draw your attention to, again, that relationship. So is there an overall increase in inflammation from the genetically that puts patients more at risk for the atopic dermatitis? It's unclear, but that prevalence was fairly significant. So why might this happen? Why might we see more of these particular conditions? So the symptoms may result in distress, including impaired sleep, which could contribute to things like depression or attention deficit, especially if they're inattentive, having difficulty concentrating. There is an increase in inflammation. So again, inflammation may be playing a role, and that psychological impact of the disease. So if they have pretty extensive severity of disease, then it may be possible that they're not going to be out and social quite as much, and they may feel guilt. They may have an impact on their overall self-esteem, which may be contributing. Interestingly, there were a couple other surveys that didn't have specific results. They were a little bit more general because they had been done previously. There was a cohort study of more than 11,000 patients, and they found that if patients had severe atopic dermatitis, the likelihood that they were also diagnosed with depression doubled. So not just having the condition, but the severity of the condition may also play a role. And there was one other study that looked at patients that were of Asian or African American descent, and they found that patients who were diagnosed with atopic dermatitis had an increase in their mental health admissions. They also were less likely to go outside, less likely to be physically active, more likely to have inflammatory changes, and more likely to have sleep disturbances. So possibly it could be a combination of those things that contributed to the increase in mental health admissions. From a treatment perspective, one agent that was thrown out there only for depression in terms of treatments. So vitamin D occasionally can be beneficial in the treatment of atopic dermatitis, may also be beneficial in some patients who have depression. So it wouldn't explain all of the mental health conditions that we see, but that may potentially play a role in some of the mood conditions that these patients experience if they're vitamin D deficient. Again, not causal. Is it the condition that then results in that? Possibly, but an interesting relationship and overlap between the two. All right, so asthma. This one I actually expected to be a little bit larger in the article than what it was. Prevalence of mental health conditions in patients who have asthma. There was a cross-sectional study of more than 4,000 children, and they screened parents and teachers for whether they felt that these children had significant emotional symptoms that were impacting their life. It was increased with both the parents and the teachers. It was actually more increased with the teachers than the parents. So we saw significantly increased reports of emotional symptoms for both parents and teachers and patients in children who had asthma. There, as part of the treatment guidelines, so the European Respiratory Society as well as the American Thoracic Society, there is a notation that for patients who have mental health conditions, specifically asthma, if that's uncontrolled, you're much less likely to be able to control their asthma. As you can imagine, if someone's anxious and they feel like they can't breathe, it's likely to increase the symptoms of both. So kind of an interesting relationship between the two that they really suggest that we're making sure we're paying attention to those mental health symptoms to try to get those under control so that we can control their asthma as well. The proposed mechanism for why this relationship may exist, again, inflammatory markers potentially playing a role, but there also was a discussion about the gut microbiome. So if there is poor microbiome diversity, it's been shown to predict the development as well as the severity of asthma in children, adolescents, and adults. It also may potentially play a role in some of the mental health conditions. Most of the exploration and attention right now is focused on psychosis, but there has been a relationship demonstrated between issues with microbiome diversity and anxiety or depression. So it is possible that that could potentially play a role. Now, how would that happen? So for someone who doesn't have anxiety, doesn't have asthma initially, how could we see a change in the gut microbiome? Well, that could be due to a number of different factors. One potential avenue is there's been a relationship identified between patient trauma and the development of asthma. So there was a cohort study that was done that looked at patients who had uncontrolled asthma, and they looked at a number of different factors that may be contributing to their uncontrolled asthma. One of the factors that came out being statistically significant was intimate partner violence. So if they had been either a witness or a victim of intimate partner violence, they were much more likely to have a mental health condition and uncontrolled asthma. So that was kind of a risk factor, at least on the respiratory side of things, that hadn't been accounted for previously, and seemed to help kick off, okay, so that could change the gut microbiome based on a number of different stress factors, including what patients are eating, but that could then contribute to symptoms of both the asthma and the mental health conditions. So very interesting. What I expected to find, and I found very little of, is the fact that the leukotriene receptor antagonists, so some of the treatments that we use for asthma, some of the pills, things like Singulair, the Montelukast, have adverse effects of mental health symptoms. That wasn't necessarily incorporated within this section, but I think it is something, it was mentioned very briefly at the end, but I think it is something that we want to keep in mind. So I didn't come across, they didn't include information about the use of inhaled corticosteroids on changing any of the emotional symptoms or the anxiety symptoms. There has been some reports of short-acting beta agonists, so our rescue inhalers, in some cases helping with anxiety in uncontrolled patients with asthma, and in other cases making that worse. So I think the role of what we're doing in terms of treatment could potentially be helpful, or it may be harmful unintentionally. So that would be something that we're going to need to pay attention to moving forward. It's kind of a spoiler for the conclusions when we get there. All right, just a couple more. Vocal cord dysfunction was the next one. This was very brief. I was surprised that the prevalence of mental health conditions in patients with vocal cord dysfunction was up to 70%. There were two, one was they both were retrospective. One was a case review, one was a cross-sectional study. They were done in less than 100 patients, but when they looked at patients that had vocal cord dysfunction, they saw a significantly increased prevalence of post-traumatic stress disorder. And I wanted to do some additional digging because for me, that didn't make a whole lot of sense. What they proposed in the article was vocal cord dysfunction may be related to a significant emotional response. So if a patient is angry or they're upset or they're anxious or they're very sad, they may have greater symptoms of their vocal cord dysfunction, which may then escalate some of their symptoms, including the anxiety of worrying about those symptoms coming back. But one of the other causes of vocal cord dysfunction, it was actually seen in more than 60% of patients who had vocal cord dysfunction was in patients who had uncontrolled asthma. So they had asthma that was uncontrolled that required intubation. And as a result of both the medications and the intubation, they ended up with some vocal cord dysfunction. So it potentially may be that some of the post-traumatic stress disorder symptoms are a result of that. So almost a reminder of that traumatic physical event when they were in a medical emergency. So I find that to be relatively interesting. There wasn't much included regarding how we should go about treating them, but really being mindful that if you have a patient that has vocal cord dysfunction, if you're even considering it, the workup may be really intrusive. So if they previously had asthma that was uncontrolled, required intubation, that further workup to get a definitive diagnosis of the vocal cord dysfunction may be really traumatizing to that individual. So it'd be important to do some screening ahead of time and make sure that there's some supportive resources available to them as they move forward through the healthcare system. Right. Urticaria and then food allergies are our last two. This one got shifted a little bit. Sorry about that. So prevalence of this, there was much more information related to chronic urticaria than with a number of the other conditions. It was interesting because they did note that there are situations of urticaria that are directly a result of an emotional response. So there are some patients that have a cholinergic response to stress, to anger, to anxiety, that may then manifest with hives, pretty significant hives. So there is a relatively direct relationship, and maybe that's why they've done some additional exploration. When I think about my kids, my students that go through the Wasson Center, so they're in the simulation center, you often see them blotch. So they may turn white, they may turn red, they may be all blotchy, but we will have some students that will break out in hives because they're so anxious in that testing environment. So recognizing that there likely is a relationship there. There were a couple meta-analyses that were done. One looked at 25 different trials, and they found that up to 33% of the patients who had chronic urticaria had at least one psychiatric diagnosis. The most common diagnosis was a sleep-wake disorder. So they had some type of issue with their sleep-wake cycle. Anxiety was the second most common. And that accounted for almost 70% of the mental health diagnosis. Anxiety and depression followed suit, relatively close behind, with psychotic disorders being a little bit farther down the line. There was another meta-analysis. This one was only of 12 studies. Those chronic urticaria patients, they were much more likely to have a diagnosis of anxiety. So the odds ratio was almost 4. And then for depression, it was almost 3. That again was in adult patients. Interestingly, they did a subgroup analysis, and they found that the risk for anxiety and depression was related to the severity of the chronic urticaria. So they were much more likely to have anxiety or depression if they had a more severe chronic urticaria condition, which seems to make sense. So for why that might happen, the burden of the disease state, so if they continue to be symptomatic long-term, that appears to play a role. But it may also contribute to chronic exposure to a bunch of inflammatory mediators. So there have been 9 different inflammatory mediators associated with chronic urticaria, and most of them have been found at a higher prevalence in patients who have symptomatic anxiety and depression. So it's possible that those two are related. Interestingly, things like our tricyclic antidepressant, so doxepin, has been used as a treatment for chronic urticaria. So it's possible that we could use some of those antidepressants, maybe not what we would think of first line because of those adverse effects, but with that antihistamine and anticholinergic actions, like our tricyclic antidepressants, may be beneficial for both of those conditions. So may help with anxiety, depression, as well as their chronic urticaria. So just an interesting observation that they found there. So last one is food allergy. This one I debated. I was thinking about minimizing it a little bit with the vocal cord dysfunction, but there are some things very specific related to this that are different than anything else we've talked about. So the NHANES study, the National Health and Nutrition Examination Survey. So this was the survey data from the 2007 to the 2010 cohorts. They found that individuals who self-reported a food allergy, about 30% of them reported that over the course of the last month, they had 7 or more days where they were significantly anxious. So days that they would say that they were anxious. So recognizing that they had some pretty significant anxiety symptoms, the authors tried to look a little bit more into where that came from. So recognizing if you have a food allergy, you encounter food multiple times a day. So maybe that's what's causing the increase. But they found a couple different things. So one, they were at a significantly increased risk for bullying. So up to a quarter of patients who had a food allergy reported being bullied. For the school-aged respondents, so those that were 12 and older, they found that more than 80% were due to a peer, but there was 20% that were due to teachers or staff at the school that were bullying the individual as a result of their food allergy, which resulted in some degree of emotional distress as well as anxiety. So that seems to be one contributing factor. The other contributing factor seems to be when the food allergy was diagnosed. For individuals who were diagnosed with the food allergy relatively early on, so something that was identified when they were an infant or a toddler, where they really didn't learn or develop certain food preferences and then need to change them, had much lower prevalence of anxiety related to food than those that develop the allergy later on. So for individuals who develop their allergy as an adolescent or as an adult, reported much more significant anxiety related to their food. And the theory was because they developed certain preferences. So certain ways of eating food, things that they enjoyed that they then needed to make modifications for. And that may be where that anxiety came from. The other interesting factor was it wasn't just the individuals who had the allergy that were reporting an increased prevalence of anxiety, but it was also the family and caregivers. So for individuals who were responsible for feeding an individual who had a food allergy, they also had an increased prevalence of anxiety, likely trying to make sure that they were paying attention and not unintentionally exposing them to an allergen. So kind of an interesting finding that was a little bit different when we looked at that particular category. So what can you do with this information? I think one of the biggest factors that came out was screening. These patients who have allergic conditions appear to be at a higher risk for mental health conditions, so we need to make sure that we're capturing that. Having uncontrolled mental health conditions may make it more difficult to treat their allergic conditions. So instead of waiting until we're not getting a response and then trying to figure out why, making sure we're being really proactive and continuing to monitor what those symptoms look like. And recognizing that some of the interventions, some of the treatments, especially the drug treatments that we're instituting and prescribing for these allergic conditions may actually contribute to some of those symptoms. So it's important that we're following up and being sensitive to, did the mental health symptoms change once treatment was started? So just as a wrap up, there's pretty significant data to demonstrate the association. We don't know causality, so which came first, or if they just happen to both happen at the same time, but there's definitely a relationship between allergic conditions and mental health conditions. So that consistent monitoring and screening is going to be essential. And while we may want to say, hey, this came first and then this happened, there are instances where maybe it's bidirectional and they're contributing to each other. So it's really important to be comprehensive and maybe take a step back for some of those patients that either aren't responding as well as you want, or that may be having pretty significant comorbid symptoms as a result of that. And that is what I have for today. Let me stop my